All right, hello everyone, and welcome. Today we're doing a deep dive into a fascinating little microbe that every single one of us is familiar with, Cutibacterium acnes. We see it all the time as a normal resident of the skin, but it can also be a really nasty opportunistic pathogen.
And really, the whole story of Cutibacterium acnes comes down to this idea of microbial duality. How can one bug be a perfectly harmless friend on our skin one minute and the cause of a severe, really tough-to-treat infection the next? Well, that's the puzzle we're going to piece together today.
You know, this bug has had a bit of an identity crisis over the years. It started out as Bacillus acnes. Then for a long time, we all knew it as Propionibacterium acnes. But the really big change, the one that matters, came in 2016. Genomic data showed it was totally different from the Propionibacteria you find in dairy, and it was reclassified to Cutibacterium, a name that finally reflects its true home, our skin.
Now this is absolutely key. Cutibacterium acnes isn't just one single entity. The phylotype tells you a whole clinical story. That IA1 type, that's your classic acne strain. But when we're talking about serious, deep infections, like a prosthetic joint infection, you're much more likely to see phylotypes IB and II. And that distinction is crucial when you're trying to figure out if what you've grown is a true pathogen or just a contaminant.
So let's follow the trail of this bacterium, from its day job causing pimples to its more sinister moonlighting gig invading sterile parts of the body. When it comes to prosthetic joint infections, or PJI, this organism is a major player. Especially in the shoulder. I mean, look at these numbers. It's responsible for a staggering 31 to 70% of infections. And these aren't loud, obvious infections. They're slow, they're sneaky, they often just show up as chronic pain, which makes them a huge diagnostic headache.
And it doesn't stop at the joints. Nope. We see it in prosthetic valve endocarditis, on pacemakers, in CSF shunts after neurosurgery, and causing these delayed infections on spinal hardware. You see the pattern here, right? It's slow-moving, it loves foreign bodies, and it is just incredibly difficult to get a handle on.
So, the big question is, how do we actually catch this thing in the lab? Well, the main problem boils down to one simple but frustrating characteristic.
Under the scope, it's that classic picture we all know, those gram-positive, club-shaped, diphtheroid-looking rods. But its physiology is its superpower. It's an aerotolerant anaerobe. That means it can hang out on our oxygen-rich skin just fine, but it absolutely thrives in the deep oxygen-poor environment of, say, an infected shoulder joint.
Okay, now I want everyone to really listen to this next part. If you take away only one thing from this entire explainer, I want it to be the number on this slide, 14.
14 days. Yep, you heard that right. 2 full weeks. That is the absolute rock-bottom minimum incubation time you need for sterile site samples like tissue or bone if you want to confidently say Cutibacterium acnes isn't there. Your standard 2 or 3 day culture protocols, they're going to miss it. And that leads to false negatives and huge delays in diagnosis. This is a message we have to get out there.
Back on the bench, it's pretty straightforward. It's catalase positive, indole variable. Of course, MALDI-TOF gives us a beautiful FAS ID these days. And remember this, it's intrinsically resistant to metronidazole. That is a huge clue that helps us separate it from a lot of other anaerobic bacteria.
All right, so we've found it. Now comes the hard part, treating it. And this is where things get, well, really complicated and even a little controversial.
At the heart of it all is this one question. For an infection this serious, a prosthetic joint infection, how is it possible there's no global agreement on whether to use Rifampin? This is a clinical puzzle that directly involves us and our role as consultants.
So let's look at one major perspective. The Dutch SWAB guidelines for PJI are very clear. For the oral therapy part, they prefer amoxicillin. But here's the kicker. They explicitly recommend against using Rifampin. Why? Because when they reviewed the evidence, they just couldn't find proof of a real clinical benefit.
So why on earth does anyone else use it? Because in the lab, the rationale is incredibly strong. We know biofilm is what causes these treatments to fail. And in a test tube, nothing chews through a Cutibacterium acnes biofilm like Rifampin. The problem is there's a huge gap between the lab and the patient. Study after study has failed to show that this amazing in vitro activity actually leads to better cure rates in people. So you're stuck weighing a theoretical benefit against very real risks like toxicity and drug interactions.
Just a quick word on kids. These infections are extremely rare in the pediatric population. There really aren't specific guidelines, so treatment is almost always handled on a case-by-case basis, using adult principles and in very close collaboration with pediatric ID specialists.
Now, for some really good news for us in the lab. Finally, EUCAST has established formal clinical MIC breakpoints for Cutibacterium acnes. This is a huge deal. It means we can finally have standardized, clinically meaningful susceptibility reporting. We can now confidently interpret our results for key drugs like benzylpenicillin and clindamycin. And notice, no breakpoint for metronidazole, reflecting that intrinsic resistance we talked about.
Okay, let's wrap this up by talking about prevention and the absolutely massive role the clinical microbiology lab plays in infection control.
The problem is, your standard surgical prep with iodine or chlorhexidine just can't get to the bacteria living deep inside skin glands. So prevention has to be smarter. We're talking about things like having patients use benzoyl peroxide washes for several days before surgery to lower the bacterial load. And we need to rethink surgical prophylaxis, especially for shoulder surgery, where maybe an agent like benzylpenicillin would be a better choice.
And this right here, this is probably our most powerful tool for infection control. There is a strong consensus now that to make a real diagnosis, to separate true infection from skin contamination, you must isolate Cutibacterium acnes from 2 or more separate deep tissue samples taken during surgery. A single positive culture just isn't enough.
Just so you know, all the information we've talked about today was put together from a monograph that was generated using Gemini Deep Search. And if you want to geek out and look at the primary literature yourself, the full notebook document with all the sources and citations is available for you. Just check the link below.
And that leads me to one last thing, a final thought for you all to chew on. We know that different phylotypes behave differently. So given how tricky this organism is, do you think routine phylotyping of isolates from deep infections should become the new standard of care? Could it help us improve our diagnostic accuracy?
What do you think? Seriously, let us know your thoughts in the comments section. We would love to hear from the folks on the front lines. Make sure you subscribe for more deep dives into clinical microbiology, and please share your own insights and experiences with Cutibacterium acnes. We're really looking forward to the discussion.